Question: a 45-year-old woman presents with weight gain, fatigue, and irregular periods. She reports easy bruising and thin skin with purple striae. Which of the following is not included in initial workup but can be confirmed the diagnose? A. 24-hour urinary free cortisol. B. Late-night salivary cortisol. C. Low-dose dexamethasone suppression test. D. High-dose dexamethasone suppression test. Note your answer, we will analyze in the end of lecture. Excess cortisol leads to fat redistribution, results in central obesity, moon face, and buffalo hump. Insulin resistance leads to hyperglycemia and diabetes. Protein breakdown causes muscle wasting and thin skin. Mineralocorticoid effects causes hypertension and hyperkalemia. Cushing syndrome. Definition: Cushing syndrome is a hormonal disorder caused by prolonged exposure to high levels of cortisol, a steroid hormone produced by the adrenal glands. It can result from endogenous overproduction of cortisol or exogenous administration of glucocorticoids. Epidemiology. Prevalence affects approximately 10 to 15 people per million annually. Aged 20 to 50 years. Female to male ratio of 3 to 1. Relevance. Cushing syndrome is a classic example of hypercortisolism and is frequently tested in medical exams. Understanding its pathophysiology, clinical features. Pathophysiology. Underlying mechanisms. Primary cause. Cushing syndrome can be caused by endogenous causes. ACTH dependent, 80%. Pituitary adenoma, Cushing's disease, most common cause, 70%. Ectopic ACTH production, seen in small cell lung cancer or carcinoid tumors. ACTH independent, 20%. Adrenal adenoma or carcinoma, adrenal hyperplasia. Exogenous causes. Prolonged use of glucocorticoids, e.g., prednisone. Mechanism. Excess cortisol leads to hypothalamic pituitary adrenal, HPA, axis dysregulation. Axis dysregulation. A pituitary adenoma secretes excess ACTH, stimulating cortisol production. In adrenal tumors, cortisol is produced autonomously, suppressing ACTH. Complications. If untreated, Cushing syndrome can lead to cardiovascular disease, hypertension, heart failure. Metabolic syndrome, diabetes, dyslipidemia, osteoporosis, increased fracture risk, AVN avascular necrosis, infections, due to immunosuppression. Clinical features, signs and symptoms. Common symptoms: weight gain, central obesity, moon face, buffalo hump, and supraclavicular fat pads. Purple striae, abdominal stretch marks. Muscle weakness, proximal myopathy. Mood changes, depression, anxiety. Menstrual irregularities in women. Physical examination findings: acne and oily skin, thin, fragile skin with easy bruising. Hirsutism, excessive hair growth, in women. Hypertension, osteoporosis, vertebral fractures. Diagnosis, diagnostic criteria and tests. Initial workup: 24-hour urinary free cortisol, elevated in Cushing syndrome. Late-night salivary cortisol, high sensitivity and specificity. Low-dose dexamethasone suppression test. Failure to suppress cortisol confirms hypercortisolism. Confirmatory tests: High-dose dexamethasone suppression test. Differentiates ACTH-dependent, pituitary versus ectopic, causes. ACTH levels. High ACTH. Pituitary or ectopic source. Low ACTH. Adrenal source. Imaging. MRI of the pituitary to detect adenomas. CT, MRI of the adrenal glands to identify adrenal tumors. Management, treatment options and guidelines. First-line treatment, Cushing's disease, transsphenoidal surgery. Removal of pituitary adenoma, cure rate, 70 to 90%. Adrenal tumors, adrenalectomy, surgical removal of the tumor. Pharmacological options. Ketoconazole, inhibits cortisol synthesis. Metirapone, blocks 11-beta-hydroxylase, reducing cortisol production. Pasireotide, somatostatin analog for Cushing's disease. Lifestyle modifications. Monitor blood pressure and blood sugar regularly. Calcium and vitamin D supplementation for bone health.